consequences from that exposure. So you can imagine, so it's very exciting to do this kind of study. You can do pieces of that, or you can do the whole process to identify. So, so in terms of metabolism of chemical, I have this slide to share with you. This is about metabolism of benzene. So in the middle here is the benzene, it's a ring-like structure. Inside the body, particularly in the liver, the benzene is metabolized by CYP2E1 enzyme to form benzene oxide and further metabolized to hydroquinone, benzene triol, and other by another enzyme, CYP2E1 also, as well as other enzymes. For many studies, we recognize these are the metabolites that are reactive to DNA and can be cancer-causing agent inside the body. So, now, however, in the body, the reactive benzene oxide can be detoxified by GSA-GST into non-toxic metabolite. So from this simple diagram, you can understand that if certain people have very active metabolizing to activate the chemical, as compared to other people who are very active in detoxifying the chemical, these are genetically based metabolism. They can be sensitive or resistant to exposure to benzene. So by knowing this kind of knowledge, we can be much more precise in doing risk assessment, right? For example, people who are active metabolizer will have more risk than people who are active detoxifying enzyme. So this is a very simple approach to address it, but this is essential. But there are also other factors that contribute to the risk. Next slide, please. So based on what I have mentioned earlier, this is a summary cartoon. Identify that on a daily basis, we can be exposed to radioactive or toxic chemical in a population. We can do population study like we have been doing for a long time to identify that they do have chromosome damage or genetic instability or cancer gene activation. So we can say that the population have been exposed and they have high increased risk for developing a health problem. But we also know within the exposed population, some of them are sensitive, will develop disease. Many of them are resistant and they have no problem. So the key here is a new scientific emphasis is to identify high-risk people to do personalized risk assessment. Well, the same diagram applied to medication to patient, right? So under the protocol, a group of patients with the same disease are exposed to given certain drug to cure the disease. Most of them respond well. Some of them may have drug toxicity, and some of them have no response. They have to change the different combination. So the same approach can apply to medication for intervention of diseases. All right, so keep that in mind. So this is what I'm going to describe in the remaining lecture and how to do personalized risk assessment. Next slide. So cigarette smoking is a good example to show population risk and lack of individual risk prediction. Next slide. For over 20 years of smoking or 30 years of smoking history, we know that among cigarette smokers, about 28% would develop lung cancer, right? And 60% lung disease like COPD, emphysema, and 22.8% develop heart disease, and so on. Of course, some of them have no health effect from the exposure, no detectable health effect. Well, so this is a population-based study, but we cannot say which cigarette smoker will develop lung cancer or will likely develop cancer, or which one will likely develop disease. We can do that for screening, for measuring blood pressure, heart rate, or doing the lung function test, but those are later stages. we need to be able to identify much earlier to prevent and intervene the disease. Right, next slide. All right, that's why a lot of the protocol have been developed to address the risk assessment process. This is an old paper that I've published, and this is a diagram. So the different approaches are listed here. So this approach can be done soon after exposure. The biomarker of exposure. You can measure, just like the cartoon I gave you earlier, you can measure biological effect in population after exposure. Can be DNA damage, micronuclei induction, comet strand break, or DNA adduct formation. And so then, as I mentioned before, then after that, from exposure, a little bit later on, you can measure the biomarker effect. Certain biological effect develop, right? And later on, the toxicity affect cellular function, right? And then further on, later on, they will show marker health risk, and then diagnostic biomarker by towards the disease development of cancer, right? So these are different time-dependent stages. Now, these are late stages that are diagnostic, and the identification of these biomarkers is useful for therapy. But that will be very late because disease had already developed. But identify these biomarkers is good for intervention to prevent the disease, to intervene the disease, right? The earlier stages is early risk for population risk, right? It can still be useful for prevention. So the important part is that all these biomarkers are designed to be along the pathway of the disease pattern, right? You don't want to do biomarkers that are unrelated to disease. They are related. So functional biomarker become a key step because this early event and identify functional abnormality, they are very likely to develop disease. So I will concentrate on functional biomarker. Next slide. So these are some line of biomarker biological effect, micronuclei, chromosomal abnormality, common abnormality by painting, the gamma H2AS assay. These are biomarker for biological effect. Next slide. All right. So I address the functional biomarkers. So it's important that you identify how to detect functional abnormality that are along disease pathway. So one of the important function is DNA repair. If we can measure DNA repair capacity in live cell, such as lymphocyte, it will be very important. It will be either because DNA repair is a gatekeeper for biological function. If repair is not done well, a lot of problems occur, as we know, for many genetically inherited diseases that are DNA repair defect, like xeroderma pigmentosum, ataxia, franconia, and so on. Right? So there have been two major assays to measure DNA repair capacity in live cell in lymphocyte. One is the repair of a specific DNA marker in a reporter gene in cell. But this process requires over 30 mL of blood and has various variation in background value. So this is kind of difficult to do, and they're still being used, but it's not very frequently used because it's the variation and large amount of blood they needed. Another assay is the quantitative determination of DNA repair capacity in a challenge assay that I developed with many collaborators around the world. So important part is quantitative, right? So that we can use the information for risk assessment. Next slide. So when we develop an assay, we have the certain hypothesis that we want to address. And so, first of all, DNA repair response is based on both inherent DNA repair capacity and toxicant influence capacity. Because we take the cell, the lymphocyte from donor, from individual donor. So the cell inherited the gene for DNA repair, as well as any toxicant influence capacity. So if we have found that people who smoke cigarettes have lower repair than people who don't smoke. So these are toxicant induced influence capacity. So because of this information, based on our hypothesis, the response is therefore variable among individuals, but unique for each one. So we measure DNA repair capacity from all of you. Every one of us have your own unique DNA repair response that is identified to you. So that will represent how you repair damage from exposure to toxic substances. So how do we do the assay? Well, we take the lymphocyte, grow them in culture, and I will tell you a little bit more about that. So when the cells are exposed or challenged with a DNA damaging agent, the cell will respond to according to each individual unique capacity. Now, if one person have lower repair, inherent or toxicant induced, when we challenge the cell, the cell would do poorly in the repair as compared to one who have very good repair capacity. So this hypothesis that the challenge response will therefore represent that individual repair capacity and future health risk. And that is essential. So we want to use that as an individual identification for response to toxic substances, as well as medication, as well as to predict the health risk, right? So let me share some data with you. So the protocol, we set up blood culture from exposed or matched non-exposed control or from patient, depending on what we want to do. Essentially, we irradiate the lymphocyte at 24 hours after initiation of culture with 100 centigrade of X-ray or with 6 joules per square centimeter of UV light at the G1 phase of cell cycle. Because these are lymphocytes stimulated to grow in culture, at 24 hours, they are at the G1 phase of the cell cycle. They are semi-synchronized. So most of the stimulated cells are in the G1 phase. So that's essential because we want to look at how cell repair at the normal status at the G1 phase of cell cycle. So after the irradiation or X-ray or UV light or with chemical, we have data or chemical also, right? Then after that, we determine frequency of chromosome at the metaphase stage, and most of you know, and 24 hours later. So we harvest the cell 24 hours after the irradiation. They look at chromosome abnormality, or we harvest the cell at 20 minutes later after irradiation, use a COMET assay to look at repair of DNA strand break. Now, so for both of them, use abnormality to determine are there any difference between the exposed or in the control individual or between patient and non-patient, right? Now, so there's the protocol. So for example, chromosome, so you know, the chromosome, we detect this abnormality, deletion, balance translocation, dicentrate, or chromatic break, and so on. So they are very clearly defined. Obviously, they are abnormal repair. Otherwise, they will not be like that, right? This is a lack of repair, right? Abnormal repair, abnormal. So this is clearly a detection of abnormality